Good evening, everyone. We are live again after a very, very long time. I think almost a month we have lost in between. So there were a lot of things going around, and we couldn't make it with the show. But we are back again. And to start with, we have taken interstitial lung diseases as the topic for today. And for this, we have Dr. Deepak Muthreja, who is the lead pulmonologist at Vivid Hospital, Nagpur. Let us welcome him and start with the topic.
Thank you, Surabhi, for giving me this opportunity to talk on a much needed topic of today. It is most relevant. Now we all know about lung
Okay, sorry, you
fibrosis.
weren't, I think, added to the stream earlier. Could you please repeat what you said?
Yeah.
Yeah.
So I said, thank you, Surabhi, for giving me this opportunity to speak on this much relevant topic of today, that is interstitial lung diseases. Since post COVID, we all know about lung fibrosis, so we would be more knowing about these diseases now.
True. So now that we are doing this for the knowledge of the general public and their awareness, we will try to explain each and every word in a more simplified manner.
Yes.
So, can you tell us what fibrosis is exactly in a simple language?
Okay. So, what happens in our body? We all know that constantly uh, regeneration and scarring happens. So, fibrosis is nothing but disorganized scarring of our tissue. Like what fibrosis we understand in the liver, which is liver cirrhosis. Similarly, in lungs, it is pulmonary fibrosis. So, interstitial lung disease are actually the diseases of lung which further leads to fibrosis. It is the end stage of the interstitial lung diseases. They start with the in lung. We know we are taking in air, and this from this air the oxygen is taken and it is distributed in our body by the blood, and the interface between the blood and the lung, that is airways, is called as interstitium. Any disease which is affecting this part, it is called as interstitial lung disease.
All right, all right. So basically, interstitial lung diseases are those in which fibrosis or scarring occurs in the lung tissue.
Yes, it is the end result of any kind of interstitial lung disease.
Okay, so this must be causing a lot of upheaval in the body because then, if the lung is fibrosed, then proper oxygen or ventilation cannot happen, and hence the blood, oxygenated blood, cannot be
Yes.
supplied throughout the body.
Yeah. So actually, what happens, as I was telling earlier, that you are inhaling air which contains nitrogen, oxygen, carbon dioxide, water vapor, and it gets vaporized when you are inhaling that mixture of air mixture, the air mixture. And when it reaches the alveolar space, alveolar is the terminal part of the lung which actually takes part in the oxygenation and removing the carbon dioxide. So the oxygen from that alveolar space goes inside the blood and the carbon dioxide is removed. So whenever there is problem in this and it gets thickened, this interface, so the disease which we call it as interstitial lung disease. So it may be because of any kind of infection. It can be because of certain diseases or autoimmune diseases. Autoimmune means the body has, or the defense mechanism of the body is working against the itself. And also sometimes it may happen without any reason, which we call it as idiopathic pulmonary fibrosis. So once this cascade initiates, the body tries to heal it. So there is disorganized healing, and during this, the scarring develops, which further leads to fibrosis. So this is how it works, and once it gets set in, there is a decrease in the oxygenation. The body, the heart has to work more, and because of which the patient have frequent chances of having a higher heart rate. And further down the line, if the scarring goes on continuing, the lungs become stiff. What we in layman language we can say, it becomes very stiff, and actually it is because of the scarring or the fibrosis.
Okay. So, how do you diagnose this? How do you diagnose this ILD?
Yeah. So a very good question, and actually it is very much needed nowadays. What happens whenever we have a cough and breathlessness? These patients are given inhalers. It is misdiagnosed as it is any kind of asthma or COPD, or sometimes cardiac failure even. So any person who is having cough which is dry in nature, matlab, there is no expectoration. The film is not coming out. One. Second, there is progressive dyspnea, which goes for more than 3 months. And certain people who are in certain occupations, like people who are working in asbestos related factories, or where the dust exposure is very high, like stone breaking areas, or where tiles are being prepared, or where the cement factories are there. So these people have more chances of developing these kinds of interstitial lung diseases. So if the patient is having a predisposing factor, and he starts developing cough which is dry in nature, or breathlessness which is progressive, that progressive means every month they are becoming more and more breathless, so one has to consider ILD as a differential diagnosis. Otherwise also, that if the patient is having continuous joint pain, or they have what people say in if I'm having a joint disorder, or in Hindi if we say that baat ki takleef hai, there are many patients who come down that, sir, we have very much so much of joint pain during winters, and they have certain difficulties in deglutition, or during drinking they are having regurgitations or symptoms of acidity. These patients, if they develop dry cough, and if they are having progressive dyspnea, so we have to suspect interstitial lung disease. Now, what happens next? Once we have suspected that he is having interstitial lung disease, we go for a test which is called as HRCT, that is high resolution CT scan. High resolution CT scan is little bit different from what normal CT with what we see. Here the thickness of the cut is 1 mm. So you find fibrosis more obvious in these tests, and HRCT is the gold standard for diagnosis. So the first step is doing a HRCT. Once you know the extent of the disease, next, to diagnose it, or to, I'll say, to have a prognostic factor, we do pulmonary function test, which goes from simple spirometry to DLCO. DLCO actually tells about the thickness of the interstitium. It tells that how much oxygen is getting diffused, and with the that is the indirect method by using a carbon monoxide tracer, which actually readily diffuses through the interstitium. So these are the basic tests what we do to diagnose interstitial lung disease. So now once we have diagnosed that the patient is having interstitial lung disease, we go ahead with the further testing, so that to know what are the reasons for the person having interstitial lung disease. As I mentioned earlier, certain occupations. Then we have if a person is a pigeon breeder or bird breeder, or having certain kinds of birds or pets at home. So these people are at a higher risk of developing interstitial lung disease. This is the second important cause. Then third, it is connective tissue disorder. As I was telling earlier, that autoimmune disorders do cause interstitial lung disease. So if so, we evaluate what the patient has, because the prognosis of the disease depends on the cause. And once we know the cause, that this is the cause of this interstitial lung disease, we start therapy accordingly. If there is no cause found, we label it as idiopathic pulmonary fibrosis.
Okay, so uh, now that we did mention about asthma and COPD, so how is this different in diagnosis as compared to asthma and COPD? I mean, how do you differentiate that ये अस्थमा नहीं है ILD है
Okay.
या ये
So,
COPD नहीं है ILD है?
yeah,
Yeah.
yes. So, see, COPD and asthma, if we talk about them as a single disease, it is a group of disease which is called as obstructive airway disease. So the problem here in asthma COPD is in your airways. That is bronchus, central bronchus, or peripheral bronchus. Like asthma affects more of central airways and COPD affects more of peripheral airways, but it is a airway disorder. So patients who are having asthma, it is actually a childhood disease mostly, and they have allergic symptoms. Regarding COPD, COPD is because of either smoking or nowadays pollution we have because of the biomass fuel exposure like chula exposure or using sigdi at home or even incense stick. So these are the noxious agents which cause COPD. So since it is an airway disorder, we need to differentiate between ILD and COPD asthma. This we can do firstly with the history. These patients are better relieved on inhalers. These patients are responsive to inhaled drugs and a spirometry. It's a very basic test to differentiate between asthma and asthma COPD or ILD. A person having a obstructive airway pattern on spirometry. This is a specific pattern in COPD and asthma, and in ILD you have a restrictive pattern. A doctor would be able to explain it to you on your test reports in a better way. So this is a very basic test which can easily differentiate between the two. Secondly, whenever a person is coming to a doctor, if he has having a productive cough, so productive cough is suggestive of COPD more than ILD. While wheezing sounds means during taking breaths, there is a whistling sound. This whistling sound is more common with the asthma and COPD than the interstitial lung disease. So these are the certain things that patient can know about himself, like wheezing, then the cough, which is with film. These are the two things which suggest obstructive airway disease more than the restrictive airway disease, where restrictive is mostly because of the parenchymal or the lung tissue involvement, basically the lung involvement. In this, the cough is dry and the shortness of breath is there in both of them. In obstructive airway disease, also we have shortness of breath, and in restrictive, also we have shortness of breath. But differentiating is that in obstructive airway disease, it is associated with wheezing, while in restrictive, it is not associated with wheezing.
Okay, that was very clear and precise. Okay, so moving ahead, now that we have discussed about ILD and that it causes fibrosis and scarring, so can you tell me whether it's incurable in that way? Then, अगर एक बार fibrosis हो गया है, तो उसके बाद क्या?
Right. So, thing is that now COVID has given us a new era of thinking. So, we used to
Uh-huh.
always think that the fibrosis is not reversible. But post COVID lung issues or post COVID lung fibrosis, I'll say, we have seen that there has been reversion in most of the fibrosis which has happened during COVID. Like I'll say that about only 20% of the fibrosis is remaining in the lung. Otherwise, the complete fibrosis gets reverted in post COVID patients. While in patients who have lung fibrosis because of certain diseases like autoimmune diseases, like connective tissue disorder or VAT, what we call it in Hindi. So these disorder, there is continuously hit phenomena, means continuously the body is acting against your lung. So these patients don't have a reversible fibrosis. So it would be incurable for them. Regarding idiopathic lung fibrosis, where the cause is not known, so this insult is continuously happening in the body, and the body doesn't get a chance to regenerate, or it regenerate itself in a disorganized manner. So this becomes again an irreversible disease. So depending on what kind of stage of interstitial lung disease we are seeing the patient, the reversibility depends on that. Yeah, once the fibrosis has set in a patient of either idiopathic pulmonary fibrosis or CTD associated interstitial lung disease, or because of any kind of exposure, as I was saying about the pigeon exposure, which is called as hypersensitivity pneumonitis, pigeon or bird exposure. So these patients, lung fibrosis is not reversible. So depending on the etiology, we can predict the reversibility of disease.
Okay, so basically the etiology, that is the cause, and
Stage
the
at which
stage.
we are sitting.
Yeah, the stage of the disease. Okay. Okay, so you did say that, some sort of I mean, if the stage is in a, I mean, the patient is in a better condition and the stage is lower and the cause is known, so then there is treatment. So then what is this treatment like?
Yeah. So now, since we are in a era where now we are continuously research work is going on interstitial lung disease. Earlier, pulmonology was only about tuberculosis in earlier days. Then asthma, COPD came into the purview. Now, this interstitial lung disease is one of the very hot topic nowadays, and a lot of research is going on interstitial lung disease. So we have two types of drugs. One is immunomodulators and one is fibromodulators. So once we know the etiology, means whether it is autoimmune or because of certain kind of, like in hypersensitive pneumonitis, we have type 3 hypersensitivity. So these are the diseases where immunomodulator acts very well. Immunomodulator matlab you modulate the immune status, like you give steroids. Now we have different immunomodulators, like we have monoclonal antibodies, we have different kind of immunosuppressive, the drugs which suppress your immunity, because your body itself, your body's immune system is acting against your lung tissue. So you are going to suppress the immunity. So you have to give immunosuppressive drugs or immunomodulator drugs. These are one set of drugs. Now, suppose the inflammation or the uh, stage where there are only fibrosis has not set in, is gone, and the fibrosis has not is setting up. So this is the stage when we recommend fibromodulators like antifibrotic agents. Presently, we are having two main antifibrotic agents like perfenidone and nintedanib. These are the two drugs which are being given to augment the fibrosis process. We slow down the fibrotic process. But if we know the etiology, treating the etiology with immunomodulator agents, like if it is a hypersensitive pneumonitis, you have to change the place where the person is working, or you have to take out all the pets or birds, whatever you are having. This is the basic treatment for people who are having hypersensitive pneumonitis. But for other ILDs, yes, you have to give immunomodulators or you have to give fibromodulators. So these are the subset of things. You have to first remove that person from the exposure. Then we have immunomodulators and fibromodulators. These are the drugs which are available.
Okay. Okay. So I also read somewhere that there is some sort of an oxygen therapy in ILD. So
Yeah,
what is that about?
correct. So now, as I was telling earlier, that once the fibrosis has set in or the interstitium has become very thickened, what happens? The oxygen will not pass that membrane, and CO2 will not come out. So what happens? So what we do, we give oxygen therapy. How this oxygen therapy helps? What you are doing, in air there is only 21% of oxygen. So by giving supplemental oxygen, you are increasing this 21%, depending on what kind of oxygen therapy you are giving. You are increasing it to 30% to 40%. Right, from 21 you are going to 30% or 40%. Since you are increasing the concentration, this oxygen passes from the that thick membrane and goes into blood, where it is available again for circulation. This is the basis of oxygen therapy. So when to initiate it, there are strict guidelines that if the person's oxygen or the in arterial blood gas analysis, it is less than 55 millimeter of Hg, or if the patient is having SpO2 less than 88, these are the patients who are recommended for oxygen therapy. Minded if patient develops certain kind of comorbidities, like if the person is having right heart failure, what we call it as a pulmonary arterial hypertension. So we know there is a left side of heart and a right side of heart. So right side deals with oxygenating the blood which is coming from whole body, and left side is more uh, involved in distributing this oxygenated blood. So if the right side is involved, so these patients we recommend oxygen therapy at a earlier stage. And this oxygen therapy can be a long term oxygen therapy in which we do evaluate patient first in 15 days, then every month, then every 3 months, how much for how much duration they do have requires oxygen therapy. And second is short term oxygen therapy, where the person requires oxygen therapy only during the time when there is a exacerbation. Exacerbation is nothing but the increase in the symptoms to an extent where you have to change the medication of the patient, or the patient is stable throughout and sudden exacerbation gives you the opportunity, or you have to give the patient that short term oxygen therapy. So these are the two types of oxygen therapy what we recommend to our patients.
All right. Oh, all right. So, yeah, so you mentioned so many treatments like immunomodulators, fibromodulators, oxygen therapy. Are these treatments very costly? Can the patients afford them in
Yes.
general?
So thing is that now, as I was telling, the research is going widely, worldwide is going on. So I was talking about the nintedanib and pirfenidone. These are the fibromodulator which is now available once the fibrosis is setting in your body. So fibromodulators earlier were very costly, but now they have the cost has come down. Like I still remember around 5 years back, if you are prescribing a fibromodulator to a patient, 1 month therapy used to go about like 1.2 to 1.5 lakhs. Now it has come down to 5,000 to 6,000 rupees, which I think is quite affordable by the normal patients. And now certain agencies, and also we can get for certain patients who are like non-affordable, we can also get it on a compassionate grounds. So the cost should not avoid the persons to go for a therapy. Regarding the immunomodulators can be as simple as a steroids, but which is very like a OTC, which is available in India. Everybody has an access to it. And with that ahead, we can also provide certain other immunomodulators like mycophenolate mephitil, or we can give the monoclonal antibodies. Yes, monoclonal antibodies is costly, but mycophenolate mephitil is not that costly for the patient. So, as now the time is going ahead, we are moving on. These therapy are getting more and more cheaper. They're not that costly.
Okay, that's wonderful news. And it's really nice for all the patients who are not that affording. So, and you mentioned about compassionate grounds. So, what is it exactly? Do you do treatment pro bono or how is it?
So what happens now? The companies like big companies like the pharmaceutical companies do give patients therapy at free of cost,
Okay,
on the basis that if they are not affording, or they have some kind of below poverty line card or something in that hand, so they give the drugs which is like a month therapy free of cost, 2 months therapy free of cost, so as to give patient that benefit which is required for his therapy.
okay, okay. So, again, audience, that's again a very good news. I hope you were listening to that. Okay, so, okay, we have a question. What to do if a patient is diagnosed with pulmonary sarcoidosis? Can the symptoms be confused with any other lung disease?
So it is actually a very good question and very relevant in Indian population. Pulmonary sarcoidosis, another diffuse parenchymal lung disease. So sarcoidosis is again an autoimmune disorder, which which many times doesn't require any treatment. So there are stages of sarcoidosis. There are only a few stages which require actual treatment for sarcoidosis, Like if a patient is having severe lung involvement, patient is on oxygen, requiring oxygen, these are the patients, or patients having severe eye problem, or there is a heart problem in sarcoidosis, these are the patients who actually require therapy. Second, regarding can it be confused with any other lung disease? Yes, the most common disease what we see in our day-to-day life, that is tuberculosis. Tuberculosis and sarcoidosis, the symptoms are nearly similar. Even the CT findings, you find the features are similar. There are nodes in the CT in your mediastinum, that is outside the lungs. You find lot many different swellings or lymph nodes. This is common in tuberculosis as well. Yes. Diagnosis, you have to differentiate between the two because therapy is way too different. So one has to be very careful while labeling a patient pulmonary sarcoidosis. You have to go through the history. You have to go through multiple CT scans. You have to do a bronchoscopy. You might require to do a transbronchial needle aspiration or transbronchial lung biopsies to diagnose pulmonary sarcoidosis and differentiate it from tuberculosis, which is an infective etiology.
Okay, Sanjeev. So I hope that answered your question. Okay. Now to ask, you mentioned about all the sorts of treatment, but these are the treatments required for people who are treatable, right? But what about those जिनका fibrosis हो चुका है अच्छा खासा, जिनका scarring हो चुका है अच्छा खासा, तो उसके लिए क्या lung transplant available है?
Yes. So now we are in an era where the lung transplantations are happening quite frequently in India also. Earlier days, like 5 years back, one has to go fly to either to America to get the lung transplantation done, like Cleveland Clinic or big clinics. Now there are many lung transplantation programs which are happening in India as well. So you have good hospitals, you have a good team which are doing lung transplantation quite frequently. And yes, uh, see, the failure rates are there in lung transplantation. I'm not saying it is totally foolproof kind of thing, but we do see failure rates in liver transplant and kidney transplants as well. Similar ways, with time, this therapy is also going to evolve. Already, I think in India, more than 500 lung transplantation have been done. These patients have are like, some people have reported that 2 years of survival of more than 80%. I feel the given a chance for lung transplantation, yes, it is very tedious, very difficult to have a lung transplantation done, but yes, one has an option of going for this lung transplantation. It is a costly affair, one thing. Second, it is very difficult to retrieve a lung organ from, because it's a cadaveric transplantation. Yeah, studies are going on for live transplantation as well. With due course, I'll explain how live transplantation would be done. But presently in India, it is more of cadaver transplant, and it is very difficult to retrieve a lung. You have to transport it in a very specified temperature, very specified medium, and the person should not be smoker. And there are a lot many criterias which make it more difficult. But yes, this therapy is available. It is effective, and if provided one has a chance, you can always seek a opinion regarding lung transplantation.
Okay. We do have another question. Okay, what's the role of BMI, weight, and comorbidities in development of ILD? Also, if IPF more common in males than in females? Is yeah.
So yes, so IPF more common in males. Yes, because predisposing factors are smoking, and we find more. We used to find more smoking in males earlier, since idiopathic pulmonary fibrosis is a disease which is seen more than 65 years of patient. The BMI, yes, it has a very important role. Like the people who are underweight and overweight, both of them have equal chance of deterioration, because the people who are overweight or whose BMI is more than 35, the oxygen requirement of the body, or what we call it as a VO2 max, is very high. These patients cannot uh, rely just on their lungs, which are fibrous, for oxygen. So these patients have, along with oxygen therapy, we might as well have to give non-invasive ventilator or BiPAP, what we call it in layman language. While other comorbidities, yes, you have to address other comorbidities like GERD, like acid reflux, is one of the comorbidity which is significantly seen in patients of interstitial lung disease. Other, these patients are more commonly to go for the right heart failure. So right heart failure is very common in interstitial lung disease. If the patient is having left heart failure as well, or CCF, that is congestive cardiac failure, these patients are at high risk of mortality. Now if I go to extremes, there are also, because if the patient is smoker, there are high chances of having lung cancers as well. So there are lot many comorbidities. Weight does play an important role, and yes, IPF is common presently in males in the studies whatever have been conducted. I cannot predict about the future. It might happen that since the smoking habits are frequently increasing in females as well, it might be a disease which would be predominant in females in a later stage, but presently it is more common in males.
Okay, so I hope that answers everything. And I guess we have covered everything related to ILD today. If you want to add some closing comments, Dr. Mutreja, please go ahead.
So first thing, what I want that as it is for other diseases, for interstitial lung disease as well, you have to diagnose it earlier. Earlier, the better is the outcome. Second, it can be misdiagnosed as heart failure. It can be misdiagnosed as asthma, COPD. So whenever a person is having cough, which is dry in nature, it is there for more than a month. If there are other associated comorbidities, like if there is acid reflux, there is obesity, one has to seek an opinion of a specialist. Third, one should not be very reluctant in going for a CT scans. CT scans, yes, it is harmful for the body, but your doctor will know about it beforehand, and he will not advise you going for a high-end tests. And one more important, a simple spirometry is a test which can be done anywhere. Mind it, anywhere it can be done. It doesn't require uh, much of any rocket science. Yes, it is effort dependent, and a technician needs to be trained. That can be done, and this simple spirometry can tell about whether the person is having asthma, COPD, or ILD. Heart failure is one of another differential diagnosis of ILDs. So one has to think of interstitial lung disease as well. And if you have interstitial lung disease, talk to your doctor regarding its prognosis. Also seek an opinion regarding lung transplantations. Yes, the cost of lung transplantations are also reducing nowadays. The cost of therapy is also getting reduced nowadays. So there is like a pragmatic shift in the treatment. What it used to be before 10 years for interstitial lung disease, where it was termed as a death sentence for the patient. Now it is not. If a person is having interstitial lung disease, it is treatable, though not curable. We can control it with different type of drugs, as rightly discussed earlier also about the oxygen therapy. Earlier initiation of oxygen therapy prevents exacerbations. Yes, there is also role of pulmonary rehabilitation. This is like the exercises you have to exercise your according to exercise tolerance also has a very good role during the treatment of interstitial lung disease. And lastly, lung transplantation, it is being done in India, now becoming more affordable, and if a person is having ILD, one can go ahead with it.
Okay, thank you so much, Dr. Mutreja, for giving us this knowledge. Even the other doctors don't have so much of knowledge regarding ILD. and for giving so much of awareness regarding this topic to the audience. And thank you for accepting my invitation for the second time and coming on our show, and being so elaborate, at the same time very precise with your answers. So thank you so much for everything.
And thank you so much for giving me this opportunity, really, because ILD is one of the diseases that is very close to my heart. Why I am saying this? Because it is often misdiagnosed as asthma and COPD, and we lose time in that. And
Right.
it's like the time is the factor here. Like in cancer, what we say now, a lot many awareness is happening regarding cancers and all. So today is as it is a World Cancer Day, but still we are
Yeah.
not talking about lung cancer. Why? Because uh, already a lot many awareness have gone into lung cancers. A lot many awareness people are aware about if they are having lung cancer, they know where to go. But
Yeah.
interstitial lung disease still we are lacking. I still remember one of my patients saying, "Ki sir, in 2015 had we been diagnosed as interstitial lung disease properly, we would not have lost the relative." So
True.
therefore, I wanted that the person should be very keen in knowing about his lung condition and mind it if a cough is not going more than 4 weeks, please seek a help of a specialist. You the pulmonologist very simple test can differentiate between asthma and COPD and interstitial lung disease. Thank you again, Surbi, for giving me this opportunity.
Most welcome. Most welcome. And it's always a pleasure working with you.
Right. Thank you so much.
So, yeah, to wrap up, we are back, and we will be continuing with our show just like that. So, please do comment as to what you would like us to cover in the future shows. Also, like and subscribe to our channel so that you know more and more about such knowledgeable subjects, and you get to meet such knowledgeable speakers. And we are all set to launch our F1 app. So, the doctors who want to log into it, do contact us for the demo. And the others, the patients and the audience, to them we would like to say that please do log on to the app, and you can find a lot of other specialties, a lot of people belonging to even non-medical things like nutritionists and other healthcare workers. So please do log into that and do check out the F1 app as soon as possible. Thank you. And this is me signing off, Dr. Surabhi Mitra, the psychiatrist and the moderator of the show. Thank you so much and have a good night.